Hello everyone, welcome to NephGems. I'm Dr. Gio Philip John, a consultant nephrologist. Today, we will be discussing regarding non-steroidal anti-inflammatory drugs, which is among the most commonly prescribed drugs in the world and is also one of the most misused over-the-counter medication. Now, let us see a common clinical scenario. This is a 72-year-old gentleman who has diabetes for which he is on dapagliflozin, hypertension on telmisartan, coronary artery disease for which he has undergone PTCA, and he is on Lasix or furosemide 40 mg once daily for his heart failure with reduced ejection fraction. He developed a knee pain related to his osteoarthritis and he was prescribed diclofenac for 5 days. Just keep this case scenario in mind, and at the end of this video, you will be able to make a decision if it is renally safe to prescribe an NSAID for this patient. NSAIDs have analgesic, anti-inflammatory and antipyretic actions and is most commonly used as a painkiller. Now the question is, are we justified in prescribing NSAIDs? Absolutely yes. That is because as per the WHO analgesic ladder, the first step in the treatment of pain is non-opioid drugs like acetaminophen or paracetamol and NSAIDs. So opioid comes only in the second step of the ladder. In order to avoid the opioid misuse, NSAIDs should be used if needed, but judiciously. NSAIDs provide their therapeutic effect through inhibition of the cyclooxygenase enzyme or the COX enzyme. So what does this COX enzyme do? The COX enzyme converts the arachidonic acid to eicosanoids, namely the thromboxane and the prostaglandins. There are two isoforms of cyclooxygenase, COX-1 and COX-2. They have separate but overlapping roles. COX-1 enzyme is expressed constitutively in many tissues and maintain physiological functions including maintenance of kidney perfusion and function, regulation of platelet aggregation, and protection of gastric mucosa. The COX-2 expression is upregulated in response to inflammation by growth factors and cytokines. COX-2 is constitutively expressed in the kidneys though. There are two types of NSAIDs based on the cyclooxygenase inhibition. One is the non-selective NSAIDs which block both the COX-1 as well as the COX-2 enzymes, and then there is the COX-2 selective NSAIDs which block just the COX-2 enzyme. The commonly used non-selective oral NSAIDs are aceclofenac and diclofenac, which are phenylacetic acid derivatives, ibuprofen, ketoprofen, naproxen, which are phenyl propionic acid derivatives, piroxicam and meloxicam, which is enolic acid derivatives, nimesulide, then there is indomethacin, which is an indole derivative, and mefenamic acid. Selective COX-2 inhibitors are popularly called as COXIBs. The most commonly used ones are celecoxib, parecoxib, and etoricoxib. NSAIDs are used as injections as well. The widely available ones are diclofenac, ketorolac, and parecoxib. Even therapeutic doses of NSAIDs can cause kidney injury. It can cause a wide variety of kidney effects. There are two types of acute kidney injury due to NSAIDs. One is the hemodynamically mediated acute kidney injury due to ATN, and the second one is the immune-mediated kidney injury due to acute interstitial nephritis. Cyclooxygenase 2 enzyme is largely responsible for increased prostaglandin production when augmentation of renal blood flow is required. That is, in situations of reduced effective circulating volume and reduced GFR, the blood flow through the glomerulus is maintained by the afferent arteriolar dilatation by the prostaglandins. So, if prostaglandin is inhibited by the NSAIDs, afferent arteriole constricts and glomerular filtration comes down. The best known prostaglandin involved in the kidney function are prostaglandin E2 and prostacyclin PGI2. Healthy individuals are usually protected from the hemodynamic mediated acute kidney injury from NSAIDs. The risk factors for acute kidney injury are increasing age when the age is more than 65 years, hypertension or atherosclerosis as evidenced by coronary artery disease, CVA or peripheral vascular disease. Here, because of renal arteriolar narrowing, the capacity for afferent arteriolar dilatation is already compromised. Second one is pre-existing glomerular disease or patients having low GFR. Here, the renal afferent arteriolar dilatation is required to maintain GFR. So, when NSAIDs are used, prostaglandins are inhibited and there is no afferent arteriolar dilatation. The third one is volume depletion, either true volume depletion or where there is effective volume depletion. True volume depletion occurs because of GI or renal loss, blood loss, or because of diuretic use. Effective volume depletion occurs as in cirrhosis or in heart failure. Here, there is already the afferent arteriolar pressure is on the lower side because of the low blood volume. The fourth one is the use of angiotensin converting enzyme inhibitors or angiotensin receptor blockers. Pre-existing kidney disease and increasing age are the most common risk factors for acute kidney injury because of NSAID. The use of an NSAID along with the AC inhibitor or ARB and a diuretic is called as triple whammy effect. This is because of the increased risk of AKI with this combination. Both selective and non-selective NSAIDs can cause acute kidney injury. The treatment of hemodynamically mediated ATN is stopping the NSAID and ensuring adequate hydration to the patient. Usually the AKI resolves completely, but it may leave some residual kidney damage. Acute interstitial nephritis can produce severe renal failure and you may need steroid, that is oral prednisolone, to aid in the recovery. NSAIDs can produce salt and water retention leading to leg edema. It can worsen your hypertension because of the salt and water retention. It can produce hyperkalemia, especially when you are using it along with ACE inhibitor or ARB in a diabetic patient due to its inhibitory effect on the aldosterone. It can produce nephrotic range proteinuria due to minimal change disease or membranous nephropathy. NSAID is one of the causes of papillary necrosis as well. Paracetamol or acetaminophen, popularly taken as Dolo or Tylenol, is not considered as an NSAID. It has analgesic and antipyretic effect but has minimal anti-inflammatory effect. Paracetamol or acetaminophen is not having a high renal risk at therapeutic doses and can be safely used in patients with low GFR. Aspirin or acetate salicylic acid is an NSAID, but the doses of 75 to 150 mg once daily used as an antiplatelet dose is not having an analgesic effect. The analgesic or anti-inflammatory doses of 300 to 650 mg Q4 to 6 hourly is rarely used nowadays. We will go back to the case we saw at the start of the video. So here we have a patient who is an elderly man with diabetes, vascular disease and heart failure. The combination of telmisartan, Lasix and diclofenac is called as a triple whammy effect. With dapagliflozin in the midst, there is actually 4 hits. You can call it as a quadruple whammy effect. It is a high-risk situation and it is better that we avoid NSAID in this patient. Thank you for listening, and until next time, stay healthy and well. Goodbye. Don't forget to like, share and subscribe to NephGems.